This meeting's being live streamed. Okay.
Yeah, you did it.
All right.
There we go. Okay, well, I'll go on mute and be in the chat. I'll let everyone know we're starting in 10 minutes.
Perfect. I'll see you in
You've
a
got
few.
everything great. Woohoo, great job.
Thanks. Hello, everyone. Who is ready for the dermatology lecture today? All right. Today we have Miss Morgan going to be our host. So if y'all have questions or comments, just drop them in our chat. We would love to talk with you today and answer any questions while we're going through. So let's go ahead and get started. So just a reminder, my name is Brittany. I'm a nurse practitioner with Arch Review. And today we're going to be going over some dermatology concepts, and you all get to even play a little game. So we're going to have a great time together. So let's get going. All right, so on our first slide, on our first slide here, we're going to talk about cryotherapy. And cryotherapy is the use of liquid nitrogen for any suspicious lesions. So can anybody put in the chat today what specific lesions we're talking about? That's right. We're talking about genital warts, actinic keratosis, really anything that seems to be, suspicious looking that we would want to kind of just destroy. All right, suturing. Let's talk about suturing now. Who can tell me what you would use a suture for? Anybody want to put that in the chat? All right, that's right. We're going to use suturing for open wounds. Anything that's less than 24 hours old, really. That's right. Uncontaminated open wounds. That's right. You guys got it. Y'all are smarter than me. Y'all should definitely be teaching here. Y'all bring up so many good points. I always love to see what the students bring. So just like IV catheters, the higher the number, the smaller the suture. So just be aware of that. Also, biopsies can be done in the case of suspicious skin lesions. So that little far box there. So it's important to numb our area and help with pain control. So just an FYI there. So there's just kind of our main review for what we can do for skin lesions or skin breakdown. All right, we're going to go on to some Lyme disease. So who can tell me what the main cause of Lyme disease or Rocky Mountain spotted fever is going to be? That's right, tick bites, absolutely. So you guys got this. Lyme disease can present in a variety of ways. Early signs are going to be that erythema migrans or that bullseye rash, fatigue, body aches. Really, if anybody has been out in the woods or just even been under some trees, maybe they went on a picnic over the weekend, they could be prone to a tick bite. So, educating our patients that they need to check their clothes and their shoes for ticks. Just an FYI, the ELISA test, ELISA, that's going to be your screening for this. And then your Western blot is going to confirm your diagnosis. The main thing for both of these tick-borne illnesses is that early detection is really important because this can progress to create cardiac or neurological symptoms. And our treatment for both of those is going to be doxycycline. So that's the main thing. Used to be we treated children under the age of 8 with amoxicillin. Those guidelines are actually kind of in the process of being updated. So if you're doing some older question books or things like that, you might run across the answer being amoxicillin. But now we're kind of moving away towards doxycycline for even these younger kids. And then the only contraindication to doxycycline would be pregnancy. So we're still giving our pregnant patients the doxycycline. All right,
Hey,
let's take a look. Yes.
We have kind of a square over our screen in the top right
Oh,
corner. Is
okay.
that showing on your side?
No, it's not. A square over our screen. Hold on just a minute. Is that better?
Yeah, that took it away.
Okay. All right. Perfect.
Thank
Um,
you.
yes, but I think I might need to move y'all just a tad so that you all can see and get the best view here. All right. Now we're going to move on to animal bites. So, who can tell me what we're going to give for a dog or a cat bite? Are we going to suture this for one thing? That's the big question. I see a lot of questions asking about suturing. And what is our answer for that? Put them in the chat. That's right. It's always a no. So we're going to look for the foreign bodies. We're going to keep that area clean. And we're going to give augmentin. That's going to be our first choice for a dog or cat bite. Okay, what about a brown recluse spider bite? Who can tell me that one? I actually had a patient that had this. Oops, sorry. Let's take you back here. I actually had a patient that had this. The area was ulcerated. In fact, this patient had it on their hand, just like the picture. Got really ulcerated. Thank goodness they didn't have any necrosis, because these can kind of become necrotic. Very concerning. The good news is that these rarely cause systemic issues, but this is one that we definitely want to take care of. And there is no antivenom for this. So this is going to be something where we're going to be really helping with, monitoring the area. They may need to go see wound care. In fact, I think that's where we ended up sending this patient to. And you're going to give them the tetanus shot if they haven't had that, and just really monitor the area and keeping it clean. That's the main thing for this one. So, okay, what about, let's see here. What about anthrax? Sorry, my slideshow's acting a little wonky, guys. Thank y'all for bearing with me. Anthrax. So this one here is one that we see more in the news than we see actually in primary care. However, the boards love to test on questions on anthrax. And so the main thing is that there are three different types: the cutaneous, the GI, and the pulmonary. The pulmonary is going to be that one that bioterrorism, those types of questions could be centered around. And cutaneous, they love to start the questions with like a farmer or a veterinarian comes into contact and has a cutaneous lesion on their hand. And so that's the one that kind of, when they're dealing with animals or even wool from animals, they can get that cutaneous anthrax. That's going to be treated with doxycycline or for those. All right, let's take a look here at our next one. All right, we have scabies and rabies. So they don't like each other, but they do rhyme, don't they? So scabies is going to be a parasitic infection, and they're really going to be itchy. And this is going to be treated just like lice. So permethrin cream, Elamite is the brand name for that. If it's a really bad case, we might give them some oral ivermectin. And some of you all might have seen in your clinical rotations the Sharpie test. I know I did when I was doing a PEDS rotation. And the clinician took a Sharpie and kind of drew on the child's arm, and then took an alcohol prep pad and wiped away, and we could see these little tiny dots, and that was where those little tiny mites were burrowing into the skin. So very interesting there, if you haven't seen that test in practice. Rabies is going to be a viral infection. It's going to come from some sort of infected animal. Does anybody have any guesses as to what animal we're very concerned about for rabies? Anybody want to take a guess there? Anybody? It's going to be bats. Also, raccoons could be one. So if anybody gets bitten by a wild animal and comes to your clinic, I would definitely offer them the rabies shots, and also like if they're going to be going into anything that is going to be working with animals, like veterinarian, something like that, we can offer them shots as well. There is vaccine for this. So, all right. Malaria. So, malaria is a parasitic illness. It comes from infected mosquitoes. This is even more common in other parts of the world. So, if your patient comes in and they're going to be doing like international travel, something like that, this is something we want to talk to them about. If they're going to an area that could be mosquito heavy, they're going to need to take something like a bug net, DEET spray. If they do happen to come in contact with an infected mosquito, though, we can diagnose them with malaria through a blood smear. And there are several anti-malarial medications that are on the market. I've listed several here on the slide for your review. All right, let's see here. What's next? All right, the Zika virus. So kind of heard of this kind of recently in the news, didn't we? And this is another mosquito-borne virus. And one of the things is it does cause hydrocephalus. So that's going to be that swelling and that fluid on the brain. It can cause severe birth defects. So there for a while, we were advising our patients to stay out of Central and South America when this was really high. So if you're going to be doing any type of international work, missions, anything like that, again, these are just some things that you might see on not only boards, but also in practice. So, okay, let's take a look at our next one is acne. So who wants to tell me what the first line treatment of acne is going to be? Anybody? Y'all can put them in the chats. Okay, so that's right. Topical treatments such as strentoin or benzoyl peroxide. Those can be drying to their face. So I like to recommend some moisturizer that's like oil-free because we don't want to clog the pores even worse, but that's going to be drying. Moderate, we can prescribe topicals such as retinoids and some even oral doxycycline. And if they are having severe acne, after we've looked at the etiology, have we talked to them about, hormones? Have we talked to them about, washing their face, removing their makeup, those types of things? And these more general first line treatments aren't working for them, we can refer these people out to dermatology, and they can be placed on something like Accutane, but you have to have a special license to prescribe that. So in primary care, you're not going to prescribe, those really heavy drugs. All right, so we're now moving on to skin infections. Who wants to tell me that first picture? Anybody have a good guess on what picture one might be? Picture one. Right. Give y'all a minute to look at that. Picture one. Okay, so that one's going to be cellulitis. Okay, so this is a classic case of cellulitis. That's a skin infection. We want to use the ISDA guidelines, or that's the infectious disease guidelines. They actually have a treatment algorithm for skin infections on there. And we are going to use penicillin as our first treatment option. So if they can handle something like a Keflex, we can give them that for sure. If we suspect MRSA, we can reach for some Bactrim, clindamycin, doxycycline, something like that. All right. How about our second picture? Anybody want to guess of what our second picture is? Give you a hint. That is some hair you're looking at in the background. Anybody have a guess? Right. So that's folliculitis. Very good. So this is just an infection of the hair follicles. You can even get this from something as simple as like a hot tub, something like that. So shaving irritation. We can use topicals like mupirocin for this. It's usually a pretty easy fix. Let's go on to picture 3. Does anybody have any guesses for picture 3? All right, let's take a look at picture 3. So it looks like another type of skin infection. That's going to be a boil. So that is going to be treated with some sort of penicillin-based antibiotic as well. In fact, you can have several of those together, and if they're a collection of them or they get to be a certain like larger size, they can be called a carbuncle or furuncle if it gets really big. So those all kind of refer to boils. Those words there. And our first line treatment is going to be some sort of antibiotic, like a penicillin-based antibiotic. Again, really good for skin. All right, let's take a look here. We have picture 4. So anybody seen a kid like this in clinic coming in? Looking like they have some stuff on their face? Anybody have any guesses for what that one might be? That's right, that's impetigo. So impetigo, they love to put those questions on there and say honey colored crust or skin flaking, things like that. This is just a localized strep or staph infection as usually the culprit. These are going to be treated with topicals such as mupirocin or any other antibiotic that treats skin. So like Bactrim, clindamycin. And then what about picture 5? Anybody have any ideas for that one? Again, the kid is your hint. Anybody can get them, but very common in kiddos. Loves to go around the daycares and the schools. It's going to be molluscum. Very good. Molluscum contagiosum, that big word there. You can see he's got it there, like right above his eye and his eyebrow, right there along the bridge of his nose. This is caused by viruses. It's spread by skin to skin contact, sharing towels, any contact that they could come into contact with the virus. Does anybody know an area, especially on a pediatric patient, where they might have molluscum and were concerned about abuse? So if I see molluscum in a certain place, where would I be doing some more questioning? Anybody have any ideas? Yes, the groin. Yes, absolutely. So genital area, groin, any of those places, we're definitely going to want to check that out, ask a few more questions. Okay, I have some more pictures for you guys. I hope y'all are enjoying this. I always enjoyed kind of, I guess, that, rash or whatever in school because it kind of helps you to, put it together and see kind of how much you know. So rash number 1. So you can see it is a round area on the hand. It's going to be fungal. Anybody had any guesses there? It's that classic ringworm, right? And depending on where it's at in the body, we have those silly little names, right? So like Tinea barbae in the beard, Tinea manum, that's on the hand. So it's all just fancy names for fungus, okay? So who can tell me a drug class that we really want to avoid with any fungals? Does anybody have any idea of what we would really want to avoid that's going to just explode that fungal infection? Very good. Yes, steroids, absolutely. So we're going to give these people some antifungals, something that ends with a Zole, Z-O-L-E, right? And that is going to help with the fungal infection, and then steroids would be something that would exacerbate it. So good job, guys. What about picture 2? What do y'all think about that one? Any ideas there? So he has a rash. It'll start out as a rash. It could even look like ringworm to start, but it's going to erupt into that Christmas tree pattern, how they love to describe it on a boards exam. So any guesses for that one? Any guesses? This is a self-limiting rash. Okay, very good. So this one is pityriasis rosea. This is a self-limiting rash. We see it a lot in kids. One of those viral exanthems that we see pediatric care. And this one's self-limiting. There's not really anything we're going to do if they're having symptoms of, itching, treat the itching. If they're, running a fever with it, treat the fever. But there's really not anything we're going to do for the rash itself. Picture 3. Who can tell me this one? Now, I'm going to give you a hint. This one here, I really want you to look at her nose. So paying attention to the nose and the nasolabial folds. So we can differentiate this one and another one by that. Classic sign there on her face. But yeah, have any ideas? So this one's going to be a butterfly rash. Who can tell me what this goes with? What disease process? Might want to draw an ANA if I saw this in clinic, or a SED rate. So we're thinking autoimmune, right? Lupus, very good, absolutely. So this one may end up getting referred out to rheumatology if we see some of those other hallmark signs, but this is that butterfly rash associated with lupus. So very good. All right, picture 4. Anybody have any ideas? We can see there is a clear line of demarcation at the midline, right? And got some vesicles on an erythematous base. They love to write that on those exams. So any guesses? Okay, that's right. So herpes zoster, very good. So remember, that's going to follow a dermatome, and you can have dermatomes all the way down. You can take those, look at those pictures of the spinal column and know where all your dermatomes run. And that's herpes zoster or shingles. That's right. This is very painful. In fact, I had even had a bout with this back in the fall. So making sure that your patient is taken care of with even the pain. We can do a lot of things to help them, from a little lidocaine, giving them that Valtrex, starting that very early, kind of helps to reduce that. And this one here is, again, just it kind of follows on the one side of that dermatome. So that's kind of how we can use this to make our differential diagnosis. It stays on one side of the body and does not cross the midline. Okay, so who can tell me about some of these benign skin conditions? Anybody have any guesses on melasma? What would cause these brown and gray patches? Does anybody have any ideas? They have any ideas for that? So this one here is going to probably be hormonal changes such as pregnancy is going to be our first guess. And sun exposure may also cause this. Again, it's benign. After they have the baby, if that's what's causing it, that's gonna go away. If it's sun exposure, they may probably need to go see dermatology. But again, it's benign. So nothing we need to go race them down the road for today. Picture 2. Who can tell me about picture 2?
Hey, Miss Brittany, we're still seeing the rashes.
Oh, okay. Let's take a look here. All right. Okay, picture 2. Is that better?
Oh yeah, now we can see the benign skin conditions. Thank
Thank you.
you.
Thank you for letting me know. All right, so let's go back. Melasma, those are those brown and gray patches that y'all see there on the far left. That's the one that's benign, but it can be caused by hormones or pregnancy. So what about the second picture, the one in the middle there? Does anybody have any ideas for that one? It's going to be vitiligo, loss of melanin. Anything we're going to do for this? Who can tell me what we're going to do for this, our first line treatments? There's no cure for this one, by the way. So they may need to be managed by dermatology long term. We can spot this out. We can give them some steroids to start, get them on over to derm. Okay, and then the third one is going to be a lipoma. That's a fatty tumor. These can happen anywhere all over the body. We'll see this a lot in primary care. These usually don't need any treatment. If they want some cosmetic help with them, or they're just like keep reoccurring and getting larger and larger, we can refer these out to either dermatology or just general surgery. Of course, we can always image these like with a little ultrasound or something if we're not sure, or it's in an area where maybe there could be lymph nodes also in the area. You know, I've even had patients have them up in their neck. We were trying to differentiate, is this a lymph node? Is this a lipoma? You know, what is this? So those little lumps, those little fatty tumors, so lipomas. Okay, what about this one here? Hemangiomas, specifically cherry hemangiomas. Again, some more benign skin conditions. These are just a collection of blood vessels under the skin. There's no treatment needed unless, again, cosmetic. They can cauterize these. They can do cryotherapy on these, but really no further treatments needed. Verruca. Who can tell me the name of verruca? The common name, what your patient's going to know. Anybody have any guesses there? That's right. They're just good old warts. So these stem from the human papillomavirus, fleshy in color. They love to be on those hands and feet, hanging around in those locker rooms, in those hotel rooms. We're going to do cryotherapy. We can give some imiquimod cream. However, one thing, if these become really painful in nature and they become like a mosaic, kind of like that one on the foot there, where they just kind of, they have like the main lesion and they've developed a lot of things around it, I do refer these out because they can become like bigger and they just won't go away. The body usually takes care of these after like, you know, several months. But if I start seeing the mosaic patterns, I try to like get on that a little bit faster so that I can give them a little bit of healing faster, and I'll send them to derm and they'll do like the cryotherapy. They'll, you know, they can even, you know, kind of cut on these a little bit, file them down, because this can become really painful there on the bottom of patients' feet. Okay, so we also have an aphthous ulcer. So who can tell me the common name for that? Anybody have any common names for that? What is your patient going to come in and say they have today with an aphthous ulcer? So that's right. They're going to come in and say that they have a canker sore, right? So this is going to be just some treatments with over-the-counter products. One little thing that I learned actually from a dentist was some magic mouthwash. The patients love this stuff. It really just helps to ease the pain and help the blister. But a little bit of viscous lidocaine or Maalox, a little bit of tetracycline, a little bit of dexamethasone. Some of these pharmacies can compound this. You can just call them up and ask what's in their magic mouthwash. And this can really help like to soothe those aphthous ulcers, especially like if you have a kid and maybe they're not eating well, we can give them this. So just something to kind of put in your back pocket. All right. So we have a few more benign skin conditions. This one here is going to be our moles and our skin tags. These aren't really going to need a whole lot unless you start seeing that they are changing. So we have the A, B, C, D, E, F, Gs of melanoma. I think by the end of by the time we all retire, it's going to be a whole alphabet. That's what I think. But who can tell me the A, B, C, D, E, F, G? Can anybody put that in the chat? Do you all? Who can tell me what that alphabet stands for? So we have all these letters. This is when we know that we need to refer out for changing skin lesions. So that's that asymmetrical border. We have changing. If it's growing, that's G. If it has irregular borders, absolutely, yes. So evolving, yes, absolutely. So those are what we're going to want to do. If, really, I just tell patients, look, we're going to kind of, chart kind of what this looks like, but the best person to kind of look at this every day is you at home. So if this is changing, if anything is looking concerning to you, you need to give us a call back. We'll send you to dermatology. And really and truly, if they have like a ton of these, I'll send them to dermatology as well, just for yearly skin checks. So if somebody just has a lot of moles and, maybe I really don't know them that well and we've just kind of met and they, maybe they're getting a little older and I'm just not real sure, I'll just go ahead and make a dermatology referral. Because you never know what's going to come out of what. And you also have basal cell and squamous cell over here, the second and third pictures. Some of the words that they love to describe is waxy and pearly for those basal cells. Again, these are skin cancers. So that is a dermatology referral. Squamous cell, that's going to be more scaly, erythematous. Hey, the scab, it just won't heal, or I picked this off and it comes back, or the doctor froze it off and it keeps coming back. I've heard a lot of those words in clinic. So that is something that you kind of want to be like, okay, so my philosophy is if it's not healing up and it looks just like a scab, we need to get that looked at. We need to have somebody to scrape some of those cells off and kind of look at them under the microscope, see what that exactly is. And who can tell me what the precursor for the for this is? Who can tell me? For the squamous cell carcinoma. Anybody know what the precursor is? That's right. That's going to be sun damage, specifically actinic keratosis. That's right. That's right. Very good. Okay. All right. Let's move on here. We have burns. So burns is something that patients will like to come in and, if it's something that we can treat, those first and second degree burns, you're going to treat symptomatically. Maybe it's a sunburn, something like that. Okay. So we're going to give them some symptomatic treatment. Second degree burns are going to have those blisters. So that's going to be what differentiates those two. We're going to give them some silver sulfidine. We're going to check that out. Then the third degree burns, or anything that looks like we can see any type of tendons or muscles or, vessels, anything like that we can see kind of, showing, that is going to need to go to the ER. That's not something we're going to treat in our office. So that needs a further referral. So that when, they can lose a lot of fluid with this is something where they're going to need more specialized care. This is just showing you the rule of nines. Most of us saw this in undergraduate. But this is just a reminder on your burns. I have had test questions that have asked you to calculate this up. This is nothing you need to memorize, but this is just something that I would be familiar with. And it basically just shows, like, if depending on how much of the body has been burned, that's the more significant the case is. That's how much more care they're going to need. So it shows you, it breaks up that body surface area. So just be familiar with this picture. I put it up here for y'all just to have as a reference. Okay, so we've already talked about this a little bit, that question at the bottom, treating candidiasis or yeast. That's a fungal infection, right? So steroids we're not going to give, right? We're going to give those antifungals. But let's talk about steroid potency. This is something that I remember when I was in school, and I just couldn't keep all these straight. So this is something that I remember, my ointments and creams, they're going to be those everyday steroids that we give. But then as we start working our way up, gels and lotions, all the way up to foams and sprays, they're going to get more and more potent. So, as we go down from spray, it gets less potent. We have different classes of steroids as well. Class 3, 4, and 5. So the lower number you go, the more potent it gets. So you can see, that these classes are going to start at over the counter and go all the way down in number and higher in potency. And then we want to avoid the face and genital areas. And I will tell you this too, when I prescribe a steroid cream, I'm talking any steroid, but steroid cream specifically, I always give them a tiny tube, and I tell them, you're going to just get a tiny amount of this. And the reason being, if we prescribe some huge tube and they go home and they use this like lotion for, days and weeks and months on end, that is going to atrophy the skin. If it does not come back, it's going to give them that white, shiny appearance. It's not going to be very pretty to look at, and that really isn't very reversible. We're going to send that to dermatology for them to look at it and figure out what to do for a plan of care. But I just try to avoid that problem altogether. So my patients love to complain, you gave me a tiny tube of that. Yep, for a reason. So if they're, just not getting better after that tiny tube, or, one more tube of that on a refill, it's time to go to dermatology. So, don't just prescribe steroids with an unending refill, because they're going to come back in 9 months and they're going to be like, well, the area looks better, but this happened. So just a little word of caution there. Okay, so let's do some questions. We have some other nurse practitioners. I know Miss Morgan is here. She is going to be helping you in the chat. If you have any other questions, we would love to hear from you. We're going to move into just some example questions now. So let's go ahead and just practice getting familiar with the types of questions they might ask us on board. So, a 2-year-old child was bitten on the hand by his new cat. Which statement by the mother indicates a need for further teaching? So I love these types of questions because it always asks in the stem of the question, further teaching, or maybe it says for understanding. So really just paying attention, because, 3 of these are going to be if she says all the right things, and then one of them is going to be she didn't say the right thing and she needs more education. So just, again, get in the habit of paying attention to your stems of your questions, asking what it's actually asking for. So any guesses here? So my child should finish the course of his antibiotic. My child should need his stitches out in 7 days. I should ensure my cat is up to date on vaccines. And D is I should ensure my child is up to date on his vaccines. Okay, that's right. B, absolutely. We're not stitching this, right? So that's right. So if they are expecting stitches, or if somebody stitched it, whatever it be, that is incorrect, because we're not going to stitch those dog or cat bites. We are going to give them some antibiotics. Of course, it's always a good idea to make sure everybody's up to date on their vaccines, kids and pets. But the stitches, that's going to be a no-go. All right, this one here is going to be a 47-year-old female comes into your primary care clinic She complains of a red papule-containing rash on her face. The rash involves the cheeks, but does not spare the nasolabial folds. What are you going to prescribe there? So we have options: doxycycline, retinol, Accutane, or Trexol, or methotrexate. So who has a guess on that one? So you can see they really want you to pay attention on those nasolabial folds. So remember that butterfly rash spared it. This one does not spare it. So what's our differential diagnosis? Okay, yep. So methotrexate is going to be our example for that butterfly rash, but this one's going to be rosacea. This one's rosacea is what this question is describing, and this one's going to be doxycycline. So that's going to be our first line treatment for rosacea. So very good. That was a hard one. Was a hard one. Of course, the Accutane is going to be for things like acne. Okay, a 17-year-old female was placed on Accutane or isotretinoin for acne by a dermatologist and comes to see you in primary care for her annual physical. She mentions she's having unprotected intercourse with her boyfriend. And which statement made by the nurse practitioner is most appropriate? So, most appropriate. So remember, when it asks that, hint, hint, most of these answers, if not all these answers, are correct, but they want you to pick the best answer. So we have free condoms for you here, okay? That could be a response, right? We need to perform a urine pregnancy test, also another response. Here is a brochure on how to prevent STIs. We're very concerned about preventing STIs in primary care, absolutely. Let's perform a pap smear today during your exam. So again, we're looking for the most appropriate response, okay? D, we're going to throw that one out because pap testing starts around age 21 per our guideline recommendations. So she's 17, so we're not really interested in doing a pap today. A and C are correct in that they're nice responses, but the big one here is going to be B, okay? When someone is on Accutane, we need to make sure that they are on some form of birth control. And we need to perform a urine pregnancy test here. So that's going to be immediate referral back to the dermatologist. We're going to need to be stopping that medication or coming off, weaning down, whatever needs to be done, and getting her off of that immediately and getting the correct birth control in place before it is restarted. So very good. B is correct. Okay, Mr. Neely, an 82-year-old male, comes in from his assisted living unit to your clinic to get medication refills. He complains of pain and swelling over his acromion process or his elbow, and upon further exam, you notice a furuncle has developed in the area. Where will you refer him? So we can see lots of little boils there over that elbow. So anybody have any ideas? So options are orthopedic specialist, wound care clinic, dermatology, or the ER. And if you put ER, you're correct. Very good. Yep. So what are we concerned about here? We're concerned about osteomyelitis, which is an infection of the bone. Anytime we see a lot of boils and infection of the skin over a bony prominence, that really will want us, warrant further workup to make sure that they don't have a bone infection like osteomyelitis. And so they need to go ahead and go into the emergency room for this one. So very good. Okay. So Libby, an 8-year-old girl, comes into your clinic for her well child visit. Her mother states she was recently diagnosed with asthma, and she's concerned about a rash that Libby has developed on her hands. What is the most appropriate response by the nurse practitioner? Anybody have any good responses? So this is eczema, and she needs a good moisturizer is A. B, this is impetigo, and she needs an antibiotic. C, this is molluscum, and it's a self-limiting. D, this is scabies, and she needs permethrin. So all of those have the correct treatment, if you will. So this is pretty much just a knowledge-based question of name that rash once we've looked at the stem. That's right. This is going to be eczema. And she does need a good moisturizer. Very good. Okay, Tina, 22 years old, college student, visits the university clinic where you're working as a nurse practitioner and states that she has painful bumps that come and go. Upon further inspection, you find some lesions in her axilla. What is your first differential diagnosis? So axilla can give us a hint on this one. I've put a picture there for you. Wants to give it a whack. Options are herpes simplex virus, plaque psoriasis, sebaceous keratosis, or hydranditis suppurativa. So thinking about where things are going to be located at. That's right, it's D. So this one here is a condition in which patients will get painful bumps, especially in their axilla and their groin. We can give them topicals. We can even inject it with steroids. If you work in dermatology, that herpes simplex virus, that's going to be more on that mucous membranes. Plaque psoriasis can be really anywhere on the skin, but this one doesn't talk about plaques. Seborrheic keratosis, that one's going to be more of that chicken skin on the arms. And then so this one is just going to be leaving you with D. Very good. Okay, so I have a little story here. Patient came into the clinic and complained of back pain. The chief complaint was a rash. It had happened about 3 days ago. And the area where it was like on the back and the side, kind of here where this is. And this patient had been kind of taking some things like ibuprofen and using a heating pad. And this is what the rash, I'll say rash, if you will, looked like. So who can tell me the name of this condition and what we're going to do with it? So I want you to think about the heating pad. I want you to think about the skin. Kind of that lacy pattern that you're seeing there in the picture. This one's going to be erythema ab igne, ABIGNE, 2 words. So this one is going to be a condition that's caused by the heating pad. It's going to be self-limiting, but we need to remove the source of heat. We can give a little Silvadene there, especially if we see any broken skin. But the main thing for this one is going to be remove the source of heat. Okay. Very good. All right, so we have a few minutes for questions and answers. We would love to talk to you, answer any questions that you have. I'll pull up the chat box here right quick for that. Okay, pityriasis, rosea, and shingles. So who can tell us the difference between those? So remember, the shingles is going to be it doesn't cross the midline, and that pityriasis rosea is going to be that Christmas tree rash. So it does cross the midline. And that one's going to be the one that's more self-limiting, whereas the herpes zoster or the shingles is going to need some sort of antiviral. It's not, it's not absolutely necessary. And if you're past that 48-hour window, you're not really going to be able to do much with it. But if we can catch it early, we can give them that antiviral. Whereas the pityriasis rosea is going to be more on their back or their trunk, it's going to be self-limiting. May not always be like a painful thing. So, any other questions? That was a great question. Yes, shingles has vesicles, right? Absolutely. They love to talk about vesicles on an erythematous base. They love to say that to describe shingles. I've seen that on a ton of test questions. So very good. Very good. All right. So that was great. Guys, y'all did a wonderful job answering all of the questions. We would love to, again, just continue connecting with y'all. If there's anything that we can help you with to, just help you gain some confidence in answering those questions. This can be a challenging area, but really the boards are going to want to just kind of know what you know superficially. And so I wouldn't stress too much. Too much here. I would just know the basics, when to refer, my steroid potency, some of those viral exanthems, rashes, some of those benign conditions, again, when to refer for those lesions that are changing. One other thing I would like to draw your attention to is the Archer Review FNP review coming up. So we're all very excited. We've been working very hard to get everything ready. It's going to be May 31st through June the 2nd. We've just got that date nailed down, so everybody would mark their calendars. For that, it's going to be a full day on Friday and 2 half days over the weekend on Saturday and Sunday. We would love to have each and every one of you come participate. And we're going to have, hours and hours of this type of content, making sure we're hitting the highlights so that you're very confident in your review. In addition, we have our new question bank. We are working towards 1,500 questions now, and so it's really exciting. We have a lot of boards type questions for you guys with rationale on that. So again, if you learn by, going through the questions and the rationales, that might be a really good option for you. We're going to continue with these webinars. I know that we are preparing several more for you all. They're free, and then also just some on-demand videos that you can take on the go will be coming soon. So I thank each and every one of y'all for participating. Y'all did a great job today, and I look forward to seeing y'all again soon. So Morgan, is there anything that you would like to, any housekeeping things that you would like to hit on before we go?
I don't think so, Brittany. I think you covered it all. Hopefully you all have taken advantage of that free question bank so you can practice. I know school gets expensive, so anytime I see that free, I definitely want to sign up and try it out. And hopefully you all will join us for that 3-day live review so we can really put that practice to the test and make sure you are ready for your exam. So we put the links to that in the chat, and we are happy if you have any other questions, you can just pop them in there and I'll make sure to answer. But otherwise, we will see you all back. We have free webinars Monday, Wednesday, and Friday. So hopefully you can come join us on Wednesday, and we will see you then.
Absolutely. Well, thanks, guys, and I'll see you all next week. If there's anything that y'all need in the interim, you let us know.
Thank you, everyone. Have a great day.